Chuck Ray, I'm a professor and vice chair of radiology and chief of interventional radiology. Interventional radiology is a little bit difficult to get your mind around because unlike most specialties in medicine that are either organ-based like cardiology or nephrology for the kidneys or disease-based like cancer, interventional radiology, the common theme for interventional is that we use imaging guidance to do procedures on patients in a minimally invasive fashion. We do things like angiograms and angioplasties, everything but the heart. So if you have a blockage in the blood vessels that go to your brain, for example, we can put a stent in those blood vessels. One of the main things we do is we do a lot of cancer work, particularly in the liver, the kidneys, and the lungs, to try and again treat people in a minimally invasive fashion. So there are two different forms of liver cancer, what we call primary liver cancer and secondary liver cancer. Secondary liver cancer is when it metastasizes, starts in another organ and then travels to the liver. Primary liver cancer can occur either in the substance of the liver, the meat of the liver if you will, or around the ducts that drain the bile from the liver. And those are two different forms of cancer that are treated a little bit differently. In the more advanced stages, what people can get is they can get jaundiced, which means they get yellow in the skin or their eyes or the top of their mouth. They can get itchy, and then sometimes people can have pain depending on where the tumors are and how large they are. The treatment option that we choose oftentimes depends on what type of disease the patient has, whether it's a primary or secondary liver cancer. So the way that we decide on the best approach for patients is we present every patient who presents to the hospital with one of these tumor types at a multidisciplinary conference. We have radiation oncologists, pathologists, medical oncologists, surgical oncologists, and interventional radiologists who all sit around one table and then discuss each individual patient and try and come up with what we think is the optimal regimen for that patient. For primary liver cancers, we almost always use chemoembolization before we use systemic chemotherapy. And the reason for that is that the results are as good or better with chemoembolization. But more importantly, we can stay away from a lot of the complications that people get from systemic chemotherapy. The most commonly asked question is, what are the complications? And the complications for both chemoembolization and SIRT, and to a degree radiofrequency ablation as well, is what we call post-embolization or post-ablation syndrome. For the most part, what it is they just feel wiped out. They just feel like they've been hit by a truck for anywhere from 2 days to 2 weeks. And rest assured that that will go away. So the whole benefit of going to a multidisciplinary institution like we have here is that you get everybody sitting around a table and talking about the same things, or the same patient, and trying to determine a course of action for that patient. So that would be the one bit of advice that I would give somebody, certainly, is make sure that you've got a whole team working for you, not individual people. Well, I think there are two things that we can offer. One is technical expertise. The other aspect to it is that we're fortunate enough to work in an institution like this that has the infrastructure to care for these patients. Not just from the physicians, but everybody from social workers to nutritionists to everybody that runs the gamut for the entire disease process. So my personal philosophy is one of trying to stick to what I know well, but then to get people the help that they need outside of my area of expertise.